Scott Hall here. Got another case for you. So this is a case of an athletic 14-year-old Asian American female basketball player. She had no significant past medical history and presented 4 weeks after an injury while playing basketball with the chief complaint of right knee pain. She was playing in a high school competition when she dove for the ball and fell to the ground. She struck her right knee with a contralateral knee and twisted her knee as she fell. The right knee was swollen for several days. There was an audible pop at the time of the injury, and she continued to have pain on the medial and lateral aspects of the right knee, which gradually improved. Ultimately, she was able to bear full weight, and she wore a compressive knee sleeve. On examination, the patient did not have an antalgic gait. The right knee had no bruising and there was no residual effusion. Knee range of motion was normal and painless. There was no tenderness to palpation along the joint lines anteriorly, and McMurray's test was normal. The right knee demonstrated normal stability with ligamentous testing. The patella was stable without apprehension and painless with a patellar grind. The dial test was symmetric and normal at 30 and 90 degrees bilaterally without significant pain. Distally, she was neurovascularly intact and had no other significant physical exam findings, but she was unable to run, jump, or twist. Due to her history and inability to return to sports, an MRI was ordered. The MRI was read by radiology as a high-grade to complete rupture of the Popliteus tendon was seen at the level of the popliteal hiatus with retracted tendon distal and medial to the tibiofibular articulation. Bone contusions were seen in the posterolateral corner on the tibial plateau and adjacent fibular head. There was no further injury to the posterolateral corner, including the lateral collateral ligament and biceps femoris. So, diagnosis: isolated Popliteus tendon rupture. Just a little bit about me. This is Scott Hall, primary care sports medicine physician at the University of Utah. I'm preparing for my 2026 sports medicine exam by reviewing published case reports and sharing some high-yield learning points. Back to the case, the patient was instructed to progressively return to her normal activity. She started with stationary cycling, then advanced to an elliptical, then to light jogging, and she was instructed to avoid jumping and impact activities for 6 weeks. After that time, she was able to resume these activities without significant pain or instability, and she was released ultimately to return to all activities and continued to play competitive high school basketball for the next 2 years without incident or limitations. So I want to talk a little bit about the Popliteus tendon and its role in this case and what you might see if this walks into your clinic. This case mentions a Popliteus tendon rupture. However, you can also get tendinopathy. It's really a rare overuse or traumatic injury. It's characterized pain on the posterolateral aspect of the knee. It tends to present suddenly when it's a rupture, and obviously tendinopathy is going to be more of a result of overuse. I want to describe the anatomy, and I've included on the thumbnail a brief drawing that I did of the popliteal muscle tendon complex. So it arises from 3 origins. The lateral femoral condyle is the primary origin, but there are also attachments on the fibular head and lateral meniscus, and it inserts on the proximal tibia above the soleal line. It is a key stabilizer of the posterolateral corner of the knee, and it functions to retard forward displacement of the femur on the tibia during weight bearing, particularly during downhill activities. If you picture the anatomy, when the popliteus muscle activates, it slightly internally rotates the lower leg or the tibia. For tendinopathy, it is an overuse injury, particularly with downhill running or walking. For a tendon rupture, we tend to think of a direct trauma or contusion. There were a couple other case reports that describes pain related to sesamoid bones, calcifications within the muscle, or even ganglion cysts. Who's the typical patient? It's going to be a recreational athlete, usually in their middle age, who increase their running activity, either the intensity or their distance. Clinically, they will typically present with posterolateral knee pain on loading with tenderness over the Popliteus tendon. They tend to have pain at the terminal range of knee flexion and have reproduction of pain with palpation and with efforts to resist external rotation of the lower leg. Having said that, both a tendon rupture and tendinopathy can present with nonspecific symptoms, and it can be a challenging diagnosis to make. It's primarily a clinical diagnosis, but certainly, as in this case, an MRI would be key in identifying findings consistent with abnormalities within the tendon. There was one reference that mentioned ultrasound could be used to evaluate the popliteal tendon. I'm not good enough with ultrasound to see this in my exam, but obviously some are. Arthroscopy remains one of the gold standards for definitive diagnosis. In the case report, I described conservative treatment with activity modification and relative rest, and that's what's recommended in the other references. Physical therapy with eccentric loading and slowly progressive therapy is what is described in the literature. There were some mentions of injection treatment with both corticosteroid injection and platelet-rich plasma injections, but those were fairly limited. And arthroscopy could be considered for severe or persistent symptoms. Prognosis is very good with conservative treatment, typically successful, with most patients recovering after several months. Undiagnosed injuries can lead to poor functional results, especially after knee reconstructive surgery. When I was doing my sports medicine fellowship in the early 2000s, this was an area that was identified as a reason for ACL reconstruction failures. That's when I first became familiar with this potential diagnosis. And tendon ruptures are often associated with other posterolateral corner injuries. Thank you.